Okay, we'll go ahead and get started. Good morning, good afternoon, good evening from wherever you're calling in from. Thank you for joining us for today's briefing. We're going to share updates on two of the ongoing emergencies that International Medical Corps is currently responding to. The first is the outbreak of Ebola in Central Africa, centered primarily in the Democratic Republic of the Congo, and to the aftermath of the devastating earthquakes that struck Venezuela in late June. Welcome, everyone. I'm Rebecca Milner, International Medical Corps' Chief Strategy and Advancement Officer, and I'd like to thank you for joining us today. I'd also like to thank the many longtime supporters who are on this call. Your generous donations make our work possible, so thank you very much. As we always try to do, we're going to keep today's briefing as efficient as possible. We know that your time is very valuable, and so our session is going to be just 30 minutes long today. We will try to answer the questions that many of you sent in, but if you have further questions that aren't covered during our time today, please let us know, and we'll do our best to follow up with you. We are delighted to have two experts with us who have decades of experience responding to conflict, disaster, and disease outbreaks. Our first expert today is Dr. John-Kall. Jill is a senior health advisor with International Medical Corps, and she's been with us since 2012. She provides hands-on and in-country support to a wide range of our responses, and she leads the team that provides oversight for our health services worldwide. So thank you for joining us, Jill. We're also happy to be joined by Ronny Elfassy. Ronny is our Senior Director for Global Logistics and Supply Chain. Ronny has years of experience in humanitarian work as a logistics and operations specialist, during which he has managed international responses and led deployments around the world. He recently returned from Venezuela. So welcome, Ronny. We're going to start our session today by talking about Ebola. As all of you have likely heard, an outbreak of the Bundibugyo strain of the Ebola virus was first declared in the DRC in mid-May, though health authorities now believe that it had been circulating in communities for several months prior to that. Since mid-May, this outbreak has become the fastest growing ever and is now the second most deadly in history. Just last week was one of the highest mortality weeks recorded, with the DRC Health Ministry reporting 317 deaths in just a 7-day period. So Jill, there are a few things about this Ebola strain and about the context of which we're operating in Eastern DRC that make it especially dangerous. Can you kind of please give our listeners a little overview of what we're facing in Eastern Congo?
Sure. Hi, everyone. Maybe first let's talk about the virus itself. So this particular outbreak is caused by the Bundibugyo virus, which is relatively rare and therefore much less studied compared to the more well-known Zaire Ebola virus species. And I think out of all the 17 Ebola outbreaks that have occurred in the DRC, only 2 have been caused by the Bundibugyo species, and that's why the Ebola vaccines and therapeutics were developed for the Zaire species. And right now, the licensed vaccines and approved treatments that were used in previous Ebola outbreaks, they're not established countermeasures for this particular Bundibugyo virus. And that's one of the central concerns of this outbreak. So what does that actually mean? So what it means is that this response relies heavily on the traditional pillars of Ebola control. So that is like rapid detection, isolation, supportive clinical care, your contact tracing, IPC, all of those things, and especially risk communication and community engagement. But the problem is, let's now move to the second big issue, is the context. So this outbreak is occurring in an exceptionally difficult environment. Ituri and its neighboring provinces face continued armed conflict, insecurity. There's large-scale displacements and frequent population movements. There are a lot of remote communities that are hard to reach. And on top of that, there's your overstretched, health services and even limited physical access for the response teams, all of which make detection and containment really, really difficult. So, and also of the current, diseases that we're seeing or disease that we're seeing, one of the alarming things, as you mentioned, like the mortality rates are going up and everything, but we're seeing that a large portion of newly detected cases don't have a link to a previous identified case or monitored contact. So what that tells us is that the chains of transmission are being missed. And when cases are detected only after people become seriously ill or after death, that means they may have already exposed their household members, healthcare workers, traditional healers, and other people in the community. So the real danger in this outbreak is that we're confronting a less studied virus without proven species-specific vaccines or treatments in a setting where insecurity, mobility, delayed detection, and the gaps with the community communication and trust also allow for transmission chains to be hidden. And those biological and kind of contextual risks reinforce one another. And I think that's why this is becoming the most dangerous Ebola outbreak that we've seen.
Okay. Well, how is International Medical Corps responding? Kind of both in the DRC, but also, there were cases in Uganda. They've seemed to have got that under control. But then also there's a big concern about it also spreading potentially into South Sudan. So maybe you could start with how we're responding in the DRC and then what we're doing to help communities in the surrounding areas prepare.
Sure. So we're supporting the Ebola response across the DRC while we're strengthening readiness in neighboring Uganda and South Sudan so that they'll be able to respond quickly and effectively if they do find Ebola cases. So, for example, in DRC, we currently operate 3 Ebola treatment centers, 7 Ebola transit centers, and 2 infectious disease units. And we're also supporting 162 additional health facilities. We conducted nearly 370,000 plus Ebola screenings. We admitted 1,400 patients. We've trained more than 1,800 healthcare workers. And through our risk communication and community engagement, we've reached about 494,000 people. And we are still going strong, and we're still continuing to strengthen case management, surveillance, IPC. Our wash guys are doing a phenomenal job getting safe water in there. And we're also looking at referral systems and also providing mental health support, because I think that's an area where there really is a need for mental health support for patients and their families.
And just the broader community because of the fear, right?
The fear, the stigma, everything else. So we are supporting that as well. And then in Uganda, we're working with our partner, African Humanitarian Action, AHA, to support cross-border surveillance, screening, IPC, WASH, and community engagement. And then in South Sudan, we're expanding the infectious disease units and also training frontline healthcare workers to detect, isolate, and manage, and also safely refer suspected cases if they happen to see them.
Okay, so you mentioned Ebola treatment centers and then you mentioned transit centers. Maybe you could help our listeners understand what the difference is between those two things.
Sure. So, in short, the Ebola treatment centers are where confirmed cases of Ebola, laboratory confirmed cases, are going for treatment. And the transit centers are where suspected patients are, and they're kind of kept isolated to see whether they do develop symptoms of Ebola, at which point they'll be transferred to the actual treatment centers.
Right. And then you mentioned laboratory testing. I mean, that's a challenge, right? So, I mean, because of the broad geography that the disease is spread over and the basic lack of capacity in this region, that's challenging, right? I mean, there is no rapid test that everybody has access, all the health workers have access to quickly determine who's Ebola positive versus not.
Correct. And one of the issues was also that in the very beginning, the tests that they have that they're used were only for the Zaire species, right? And then those people were found to be negative because they were using this other, they were sick with this other species. So now that they found that out, of course, they're testing for the right species, but it is not easy. DRC is a massive country. The roads are difficult to just navigate. There's insecurity. It's a lot. And so I think when we see the number of cases rising, it's not exactly surprising, but that's why we have
Right.
to kind of continue doing what we have to do.
Right, right. And our treatment centers, I mean, our smallest treatment center, I think, is 20 beds, and then our largest is 100 beds.
Yeah.
So it's also the treatment centers are sort of, where you, as you said, the confirmed cases go, but the transit centers are more in the communities, right? So that you can try to reach as many people as possible, screen them, and determine who is at risk and who might
Yeah.
be positive. And then we refer them to the treatment centers.
Correct. And also, we are supporting 162 other health facilities. So,
Right,
because we just don't have the resources to set up transit centers everywhere. And a lot of the
right.
transit centers are actually attached to hospitals, but
Mhm.
the hospitals also have to be careful. If they have someone with suspected Ebola, they can't let them into the hospital without
Right,
screening, et cetera, right? So,
right,
even at those health facilities, we've trained the health workers to kind of think, because one of the other problems is when Ebola initially presents, it could be a number of diseases. It could be malaria, it could be typhoid. They're very vague symptoms, like fever, malaise, those kind of things. So
aches. Right,
trying to, yeah, we're trying to, make sure that the healthcare workers are really kind of thinking about Ebola, even if they need to suspect it before they do anything else. And that's what we're training them on so that they can
right.
do detection. Yeah.
Right. Well, Ronnie, I mean, one of the most important components of an Ebola response is ensuring that health workers interacting with patients have the personal protective gear that's necessary to keep them safe. I mean, please give us a sense of how much PPE is needed for these activities. How does International Medical Corps manage the supply chain of PPE? I mean, I gather that our stocks of supplies are measured in weeks, not months, which is
Mhm.
the way you like to plan, right? Like for every contingency.
Yeah, I mean, you're actually even looking at every bed you have, and then how many changes of coveralls you would need per day for that bed, and then you have a multitude of other PPE like gloves, masks, all of that. So just to give you a sense of our operations right now, we're looking at 45,000 coveralls per month that we need based on 360 beds. That's just the coveralls, right? And then you have all the other PPE that you need to get. So for us, it is a major challenge. I mean, for anyone, it's a major challenge to respond to this because what happens is you're going to your vendors, they're not used to keeping that amount of stock. And also, these are specialized coveralls. You know, you need a special type of coverall that you can use for Ebola that will be safe for your staff. And it's not something that they typically carry. And so, what we do, first of all, even during Blue Skies days, we maintain very strong relationships and partnerships with our vendors to make sure that if something like this happens, that we're kind of first in line, whatever stock they have available, they can quickly reserve it for us, and then we can procure it and deploy it. Typically, what will happen is that they'll have a certain amount available, and then they'll have some lead times on back orders. So as soon as they produce more, then they can give you more in chunks. That also complicates things because then you're not shipping everything in one shipment. You're having multiple numbers of shipments, and every time you're shipping something, I mean, it's a struggle, right? We know
Yeah,
especially in
uncertainty.
DRC,
Subjective.
yeah, so we're looking at freight costs. Freight costs are very high. I mean, we're transferring massive amounts of goods, and we need to transfer it by air because, first of all, it's urgent and we need to get it there, and that's basically the way that we get it. Dr. Jill alluded to some of the challenges that we have in terms of the conflict and danger around transferring supplies by road, and so when we look at where we're responding and we look at the last mile, how do we get the PPE and the coveralls to where they need to be to our transit centers or to our treatment centers? We have two routes. One is we bring supplies into Entebbe through Uganda. And then the other route is that we bring supplies in through Rwanda because the airport in Goma is closed. So we can't actually bring them in there. So we look at those two rights to bring things in, and then once we get them there, to then bring coveralls and PPE to different centers. When you're looking at a multitude of challenges in terms of risk, Sometimes trucks just won't go to specific locations because it's too dangerous. We want to also ensure the safety of our supplies. And so we have to work with authorities, we have to work with the actors over there to make sure that we get our supplies across safely. And so what's happening here is basically you have a few NGOs, WHO, and other actors that are responding. Everyone's kind of trying to look at the market. We're looking at what's available locally in DRC, but also at global vendors. But typically, we're going to similar vendors, right? So what we want to make sure is that we're not competing with each other. And so what I saw, and I have to say, I think this is one of the best times that I've ever seen information sharing between different NGOs and WHO. I mean, immediately they had asked everyone to provide their pipeline of PPE and put it up on a dashboard so we can all see whose supplies are coming when. And then on the ground, you can work out like, do we borrow or loan based on other people's pipeline? And it's really incredible. I mean, everyone's sharing information and working with each other. And not only the NGOs and WHO, what I saw that was interesting is that the suppliers are also participating. So we're having calls with major vendors, with NGOs, with WHO. We're all kind of participating together on the call to give the vendors our pipeline, what we're looking at, what we're going to need, and then they can they can plan properly for their manufacturing. So it's been a lot
Right.
of information sharing and a lot of partnerships that way.
Wow, that's great. That's super positive. I mean, it's just such a challenge, right, to keep our colleagues safe around that. Well, before we get too far into the weeds, I mean, let's do a little shift and talk a little bit about our response in Venezuela. I mean, as everyone remembers, on June 24th, Venezuela was hit by two kind of back-to-back devastating earthquakes. The quakes caused severe structural damage across several states within Venezuela, especially La Guaira, leaving more than 6,300 people dead, nearly 17,000 injured, and some 24,000 people still displaced from their homes. And then, unfortunately, kind of many thousands more are still missing. Um, Venezuela, we already had a team in country, and so we were able to begin our response immediately. People, when the earthquake struck, I mean, the team inside began assessing conditions and immediately set up some mobile medical units. But then we, kind of outside the country, also sprang into action, deploying our Type 1 emergency medical team, both fixed and mobile facilities in response to the earthquakes. So maybe Ronnie, you can kind of give us a quick overview of how we kind of coordinated that, working locally as well as kind of bringing in the international assistance and how we deployed the EMT, which is essentially an outpatient field hospital, right?
Yeah, yeah. Yeah, I mean, we have constant steady state monitoring at headquarters where we're looking at things that are happening around the world. And as soon as an event like this takes place, we immediately spring into action to talk about what kind of response would be appropriate while the team on the ground is conducting needs assessments, discussing with the Ministry of Health. In this case, the government put out a call for support, for help. And so we had the UN come in to coordinate that with WHO, with PAHO, who had basically expressed that the need for these EMT type ones. So we immediately said we're able to do something like that. What that looks like, that's 150 pallets worth of supplies. It's about 35 tons. I looked at a way to equate it. It's about 6 elephants worth of weight. It's massive. It's a massive load. And it's 35 staff that we have, a team of 35 that deploys to set it up and to run it. And so what happens basically at the headquarters is that you have us alerting our vendors and our partners as soon as possible. This happened. We might need to deploy. So we have most of our supplies that are stored in Memphis. They're stored by FedEx. They support us in this. And so we alert them right away saying, we might deploy. Can you help us? And they basically start getting all of the supplies ready. So we review the items. We make sure that we look at what's appropriate for the country. So in terms of weather, what kind of tents do we need? What kind of supplies do we need? In terms of medical supplies, what are we allowed and not allowed to bring into Venezuela? We look at our dangerous goods like generators and other medical equipment with lithium batteries because all of that needs to be prepared and labeled only after we know where it's going. So that's always the tricky step that we have, that it
Right.
waits. And then the difficult part is securing the freight. So we're looking at chartering a plane. Not too easy to do, especially in these situations. The airport was closed. But we did manage to get a charter with working with our partner Airlink, who had established an air bridge with the U.S. State Department. And then while we're doing that in the field, we have our team basically doing an assessment. So they're looking at different sites, talking to the Ministry of Health to make sure that we go where we're most needed. We're looking at how we do import clearance, securing vehicles for all of our staff and for movement, securing fuel, making sure we have electricity, looking at accommodation. We have then our wash team trying to secure water, making sure we have water, latrines as soon as we go, securing a company for medical waste, for pickup of medical waste to be ready right away. And then looking at engineers to do structural assessments and contractors. So we're all doing that at the same time. And then basically what happens is we all converge once the supplies get to the airport, which is always a really exciting moment to see it come off the plane. Then we're on a deadline, right? So we were looking at about 48 hours to set the whole thing up. So we have our logistics team, our wash team, and our medical team, and basically everyone's working into the night. It was just incredible to see the local team that had just been through this trauma, but basically they were up and running, putting all of their effort into it to get this thing opened. And yeah, 2 days later, I mean, we opened our doors to start seeing patients, and we got to roughly about 140 patients a day. So we were busy, and we were definitely needed in that spot.
Right, immediately, right. So the
Mm.
outpatient facility provides, a fixed location where everybody is, and they come to the facility. But then we also have a strategy of sending mobile teams out into the community. Maybe you could talk a little bit about how that works as well.
Sure. So we had four mobile medical units basically that we set up in specific spots. There's a few ways to do this. You can assess on a daily or weekly basis where the need is highest, and then basically go to that place. And everyone's coordinating with the Ministry of Health, coordinating with WHO to make sure that we're not overlapping and we're coordinating our efforts. That's what basically we were doing. So we had four different teams that would go out with large vans. So we had I believe it was about 15 staff in each van that would go out and set up these mobile clinics in areas that in remote areas that weren't getting the assistance that they needed. And those vans were able to also move supplies and support the communities there. And also, if needed, those vans and vehicles were able to transport patients if we needed to refer them to bigger hospitals that have more capacity. On top of that, while we were doing that, our teams were also conducting water and sanitation assessments in different communities that got hit by the earthquake, because that's a really major component to prevent any kind of outbreak of disease from dirty water spreading. So our teams went
Right.
out there, they assessed some sites that were in need of water, and we set up tanks and we set up water trucking to make sure that those communities had clean water on an ongoing basis and provide them with some hygiene supplies. At the same time, we were also providing support to the Ministry of Health existing facilities, the ones that were up and running, whatever we could do to support them. And then on top of that, the last component I would say that's outside of our outpatient clinic is that we had a mental health and psychosocial support tent that was up and running on our EMT site, but also was coordinating with the Ministry of Health as well. And we were doing training of psychological aid training of staff over there. But also actually we had therapists, and we were actually running therapy sessions in our tent, and that tent was very busy. So that was an add-on to our
Right.
EMT.
Amazing. Well, Jill, I mean, we're 8 weeks out from the kind of immediate response. I mean, what are the things that we're concerned about right now in these communities that have been impacted by the earthquakes?
So I think it's easy to kind of think that the earthquake is like one event and then it's over and then, everything gets better and better. But I mean, you heard, everything that Ronnie just described, that was like the immediate needs, et cetera, et cetera. But 2 months on, the health emergency hasn't ended. It's just changed a little bit. So for example, the immediate trauma burden would be now compounded by, there's still displacement, overcrowding, damaged water sanitation, there's damaged health infrastructure, and all of this kind of heightens the risk for respiratory diseases, gastrointestinal infections, skin conditions. We also have to think about life-threatening exacerbations of chronic diseases because their treatment was interrupted. And that could lead to hospital emergencies, etc. We also have to think of rehabilitation, like physical rehabilitation needs for all those people who had like trauma during the actual earthquake. And of course, the last thing Ronnie was talking about was like psychological distress. And I think that's particularly important among children, caregivers, older adults, and honestly, even healthcare workers. So for us, we kind of continue to respond through our mobile medical units, and our EMT, our fixed EMT. I think we've provided nearly 9,000 consultations, more than 800 mental health and psychosocial support consultations. And I think just from the WASH side, we've also provided 530,000 liters of safe water to affected communities. And I think that's really important because if you don't have safe water, that can lead to a cholera outbreak or something else.
Sure.
And
Sure.
for our medium-term approach, we are going to maintain access to essential care while progressively supporting the reestablishment of existing health facilities, referral pathways, supply chains, disease surveillance, more water and sanitation kind of
Right.
infrastructure.
Even rehabilitation if necessary.
Exactly.
Physical rehabilitation. Yeah,
Yeah,
the
and we
facilities
do all
themselves.
that along with the ministry. So we're not setting up,
Mhm.
like
Parallel.
parallel systems, because what we want
Right.
to do is encourage the existing systems to take over. We're just there to
Right.
fill the gap, during the emergency. And also, as displaced families relocate, we're also adapting our mobile outreach to reach remote and underserved communities, while also helping the health system to transition from a temporary emergency services towards more safer kind of locally led care, which is really our aim anywhere we go, to be honest.
Right. Right. Well, I mean, this has been, I think, fascinating and really great to hear updates about both Ebola and Venezuela. We like to end on a little bit of a positive note. So, Ronnie, maybe we could start with you. I mean, sort of what has encouraged you about both of these responses that, you know, give you hope as far as the developments there.
Yeah, I mean, I think I mentioned the coordination, cooperation between the NGOs and between suppliers. That really, in the Ebola response, was really amazing to see. And then in Venezuela, again, our team there, I was just so amazed and inspired by them because I knew what they had just been through. And they were honestly the next day, they were out there. And when you go out to do those assessments the day after an earthquake, you're looking at search and rescue teams. Those are difficult sites to watch, but they were out there doing it. And when we kind of grouped together, I mean, it was just an amazing partnership. There wasn't any kind of friction or anything. It was right away, like we're all working together for the same thing. And what was really cool to see is that vendors, like suppliers in Venezuela, all wanted to help us. So we were set up at a hotel. The hotel kept coming to the site to bring us things that we needed or bring us food or anything that we needed. They would just help us out for free. There were things like we would go to a fuel station to fill up canisters of fuel, and we would tell them who we are, and they would just say, "That's okay, it's free, like take it." Everyone was just so supportive of what we were doing, and that was great to see.
Amazing. What about you, Jill? What do you see as a positive?
I'm actually excited for our work in DRC, even though it sounds, like it's an impossible kind of hill to overcome. But our team in DRC is just about to start taking part in the therapeutics trial for the Bundibugyo species. And we're also in discussions to join the vaccine trial, both of which could go a really long way in getting some answers. And we're also exploring AI-enabled tools that can improve patient care, patient management, and put less burden on the actual healthcare workers who, when they're going in to see their patients, you have to imagine like what
Right, all
I was explaining earlier. Yeah, they're all fully with, PPE. They can only be there for like a few hours at a stretch, et cetera, et cetera. So I think we're doing really good work there. And in Venezuela, our team, they're doing a great job handling this earthquake, even though, like what Ronnie mentioned, they are part of the affected population. But they are working with local health authorities. They're continuing our routine work. And I'm going to be there next week. So I'm very excited to support them and see that all the great work that they've been doing. So that's a positive note for me.
That's great. Well, our time is up. Just wanted to thank everybody for joining us. If you support International Medical Corps, thank you. I mean, we couldn't do our work without our incredible partners and donors and supporters. So thank you very much, and we look forward to seeing you on the next briefing call. Thanks, Jill. Thanks, Ronnie. Okay, bye, everyone.